Okay, thank you for coming today. This is the July 16th meeting of GLIMPRINT and the IMAG MSM Working Group. We have a talk today from the Technion Institute on lessons learned from COVID. As always, I need to remind you that the meeting is live streamed and made available in edited form for public viewing afterwards. The team consists of myself, James Glazier, Tom Helikar, co-lead, Lorenzo Veschini, and Ellen Kardakos. We're all available to take your comments and suggestions for improvements. Please feel free to reach out to any of us to tell us what we can do better, make things more effective. If you find the seminar interesting and you'd like to hear more on related topics, please consider joining GLIMPRINT and also subscribing to the YouTube feed that's available with the links that are going to be put up on the YouTube edited video. GLIMPRINT is a membership organization. We could do more if we have members. We're asking for $100 per year for staff, faculty, $10 a year for students. If you want to join and that seems unreasonable, please reach out to us. We're also interested in corporate and institutional sponsorships as well. Please think about joining us, helping us build this community. We have a variety of social media and websites, the glimprint.org website, the YouTube archive, the old IMAG MSM wiki page, and there's a Slack channel and a next channel that don't get as much use. There's also a LinkedIn page as well. If you have a publication to share or conference to announce, anything of that kind, those can go up both on the IMAG MSM page and on the GLIMPRINT page. You can put those up on either place. If you have questions, reach out to lnmq@iu.edu for help. We have one more seminar next week in this series. Andrew Sage from Toronto General Hospital, Digital Twins of Human Lungs. Then we are going to take August off and start again in September. We are going to try a new time, which was requested by a lot of participants. It's going to be noon Eastern time, US time, on Wednesdays going forward. And we have meetings scheduled for September 9th, the third place winner of the Open VT Most Reproducible Model competition, and September 23rd, the first place winner from that competition as well. Please suggest people you'd like to hear. Feel free to suggest yourself, your students, your postdocs, anyone you'd like to hear in the broad area of multicellular modeling, digital twins, and immunology. Could be experimental, computational, theoretical, drug delivery, and be open to quite a wide variety of topics. And we always appreciate suggestions of people that we might not have thought of. So we have today a talk from Drs. Goldberg and Dr. Hubert, lessons from COVID-19, data, trusted decision-making in times of crisis.
I will interject here. This is part of the lessons learned series from COVID-19. So this is the the fourth talk on this one. Hopefully we'll have more. We're exploring what other people have experienced modeling during COVID-19. Today it's Yair and Amit. They wrote 2 papers together, and those are the papers. They have many lessons there. 12 lessons that I counted. I'm going to skim through the lessons. If Amit catches something he likes, then I can stand. But basically, I have 12 pages of lessons and 12 pages of recommendations. We're not going to talk about all of those. I'm just going to show them all for now, in case someone will be interested later on to look at any of those. So as you can see, I'm scrolling down. There are a lot of information, and we cannot condense it within 1 hour. I rather have Yair have more time to talk about those things. And there are many recommendations for actions to take. Again, 12 pages of those in slides. I will stop when we get to the Q&A because there are questions and answers we ask all of the presenters who present in this series of lessons learned. Those are the questions. I will yield now my sharing to Yair so he can share and show his presentation. We'll get back to this when questions and answers start.
First of all, thank you all for coming, and thank you, Jacob, for the invitation and for explaining me and talking to me. I had 2 meetings with Jacob discussing this talk and in general modeling. So I talked to Amit, who was supposed to give this talk together with me. He's in Africa, and he was supposed to be in his hotel, but he's stuck in traffic for a few hours now or something like that. He sent me a WhatsApp and apologized, and this is really pity. I really wanted him to talk because we work together. It's the same team. I'll explain what our team did, and his part is different than mine, and he has a lot of experience to share. Amit is in the Gertner Institute, which is the epidemiology center of Israel, and in Tel Aviv University. I'm from the Technion, the Israeli Institute of Technology. Amit is the head of biostatistical and biomathematical units in the Gertner Institute in Sheba Hospital, which is the biggest hospital in Israel and considered to be one of the best in the 10 best hospitals in the world. And I'm here. We have no competing financial interest to disclose. So this talk is about, I would say, 2 main things. First of all, about the people who work on the, I would say, on the pandemic, and the other is on the data. I think this is going to be my 2 main lessons to discuss. And after I'll explain a little bit how it worked, both regarding people and the data, I'm going to talk about a specific case study, I would say, related to the decision in Israel to do the booster dose. And I'll just summarize, and you are most welcome to ask questions or write to me, and someone can tell me if there are questions as I go. Okay, so a little bit to understand what's going on, and because Amit is not here, I can actually explain that this is all Amit's doing. At the beginning of COVID, it was understood that this is a real crisis. And at that time, Amit himself went to multiple universities, research centers, and organized many teams. I would say about 10 different teams or something like that, working from multiple universities, gave each team a question to do. And people just wanted to help and did that. In the beginning, it was how many ventilators we need to buy to Israel, what to do, how to decide who should get the treatment at the hospital if there is not enough beds, etc., etc. Some of that ethics, some of that technical, some of it how to do, what is R, how many people are infected now, what's called nowcasting, stuff like that. That was the beginning. Most of the people worked in teams. Again, people worked from home mostly, but we still had meetings at the beginning, at least in the Gertner Institute, until there was a lockdown in Israel. A lot of volunteers were part of these teams. Many of them are senior military officers in Israel, officers in the army, usually go to a different career at age 45 or 50. So we got in our teams many really senior military officers with a lot of experience who also joined us. We even got people from the army themselves. The army was agreed to assign programmers. I worked a lot with a programmer, a great guy, young, like 20 or something like that. They just worked on modeling the pandemic with me, doing computer programming and stuff like that. So they helped us, and a lot the Ministry of Health. So the Ministry of Health got a lot of help from volunteers, researchers from the universities, and from the military. And this worked as written here. work on multiple urgent tasks, including disease monitoring, forecasting, hospitalization burden assessment, the development, and this is very, very important, the development of national data infrastructure. And data is really, I think, one of the most important things here. A little bit about these teams. At the beginning, it started with many people. After, I would say, 2-3 weeks, it stabilized about, I would say, 4 or 5 teams or something like that that work together and usually met once a day or something like that. And Amit was really running all of that, and that I'm so sorry he's not here to explain that. But anyway, the team produced analysis, really real-time analysis. This analysis went directly to the Ministry of Health in general, and in some cases to senior government level forums. Amit himself talked many times to Bibi and Bennett, our prime ministers at that time, and was joined the government meetings and stuff like that. And at that time, in this beginning of the pandemic, March to June, Israel was in a total lockdown. People were not allowed to walk out of their homes to more than 100 meters. Really, people really didn't go anywhere. And at that time, it was understood that we have to open the schools, we have to open the state. And one of the main, I would say, product of this period was what's called the Gertner report, which you can see here. We did it in 5 days. We wrote the whole report. This took all the main newspapers in Israel at the date it went out. And also you can see here other some other publications, mostly in Israel. But after that, it was decided to open the schools, but in what's called capsulas, which means every day, not all of the students come to school. After that, the lockdown was stopped, and it was after the first wave. Things went back to normal. The intensity of the work decreased substantially. Most volunteers and many academic researchers returned to their regular positions. So volunteers, for sure, this is clear. They really worked for about 3 months for free and worked very intensively. But researchers in academia, most of them had to go back because they had to teach. They had to do, their own research, because you don't get a lot of promotion by working with the Ministry of Health. And it was decided that anyone who has no tenure has to go back, and others, most of them just go back anyway. There was only a small core group that continued to work with the Ministry of Health. And the focus shifted from emergencies that was in the beginning to continuous analytical support. And this is again, I think, a very important lesson. The period preserved key expertise and infrastructures that later become important again. The next period of interest is July to December 2021. After the vaccination in Israel, vaccination started on December 2020. And it's helped to stop the third wave in Israel, the Alpha wave. And things went back to normal. And at that time, we statisticians still continue to work on vaccine effectiveness of the second vaccine. But already back then, Amit told us, you have to start to work on waning immunity. So already during March 2021, way before, Israel was just vaccinated at that time, we already started to make the models and to understand how to analyze data in case of fading of the vaccination. And there was no COVID in Israel at all during April and May 2021. And the only data we collected was from the border control, so back then. At that time, so that ended at the beginning of July when the Delta wave started. At that time, two parallel professional teams were formed. One is an epidemic modeling team, including Nir Gabish, also from the Technion, Rami Yaari from the Gertner Institute, and really by chance, he's my first cousin, and Guy Catriel, who is a modeling guy from Ort Braude in the north, also a great modelist. At the same time, the statistical analysis team, which I'm part of, which included, we still had one soldier that stayed with us, one or two students and some researchers from different universities. Amit was in both teams. He ran both teams. The team worked across the full analytical pipeline from extraction and cleaning of the raw data. We really went down to the data in the Ministry of Health, which I'm going to explain it in more details in a second, and going through the analysis, modeling, interpretation, and reporting to officials of the Ministry of Health. The work remained closely connected to senior decision makers with regular presentation to what's called the Israel National COVID Expert Advisory Team, or in short, HATSATAM, which is a big body of people who are all expert, people who are running the HMOs in Israel, people who run the hospitals, and other experts from different fields. And they decided on mostly on what, or at least recommended to the Director General of the Ministry of Health what to do. So we presented our work regularly at their meetings. I mean, Amit is a member of the Chatam. I'm not. Okay, so this is our team, and Yinon is one of our students, and Omri was part of the Ministry of Health, but mostly he was borrowed from the army, and both of them really looked into the data of Ministry of Health and got the raw data out from there. We were a team of statisticians, Micha Mandel from Hebrew U, and myself. And we had a lot of advice from Lawrence Friedman, who is a senior statistician. We also worked with Ron Milo from the Technion, who was really presented our work, was part of our work, and presented it mostly to Sharon Elroy Price, who is the head of public health, and also to Nachman Ash, who is the Director General. So it's really from the data, from the raw data, through the analysis and modeling, and to presentation, reporting to the high officials, I would say, of the Ministry of Health. This is the team that worked this is our team, and the parallel team of modeling did the same with people more mathematicians and less statisticians. Okay, as I said, the data is I think, very important part here. So this I took actually from slides of Nachman Ash, who was in the beginning, was I would say, handling the project manager of COVID in Israel, in the Ministry of Health, and later on he became the Director General of the Ministry of Health. He's well known. And the data that was collected by the Ministry of Health they got it from 46 hospitals, 56 laboratories, 1,000 geriatric and mental health institute, private sector, public sector, 100 testing operators, 4 HMOs, and from the border control. We got all of that. I mean, all of that data went to the lake of data of the Ministry of Health. So I have a slide that just show how complicated is the data structure. It goes from so many places to the lake of the data in the Ministry of Health, and then goes out using the BI, to researchers. Everything is, because of privacy and because of all it's so complicated, but all the data, and this is a unique situation. It's never like that in Israel. Really, all the data from all hospitals, all labs, all HMOs, everything went daily to the data lake of the Ministry of Health. And then people who, within the Ministry of Health, who takes the data. And although I'm from the Technion, I'm not from the Ministry of Health. With the help of the Ministry of Health people, we could analyze the data on their computers. So to explain a little bit why it works. So first of all, Israel has centralized electronic medical record system, which is good. And the data was really collected daily and even sometimes twice a day. The data is linked using the person national ID number. Everyone has one ID number, and you go with it to whenever you go to do testing. It's written and linked to your data in the HMO, which is linked to everything. All of that is linked only in one place, in the Ministry of Health. I mean, it's all, of course, anonymized and no access from outside. It's all on their servers, of course, but everything is connected. So for us as researchers, but we were able to combine data from the Ministry of Health, the Israeli Central Bureau of Statistics, and we obtained for each resident a lot of data. For example, the municipality of residents, which is important because in different cities in Israel, there were very big differences in how much infection was out. Age, all PCR tests, all can be hundreds if you are a worker work in the hospitals. Infection days, first, second, and later on, fifth, seventh, whatever. Vaccination date, first and second, if applicable. At that time, later on, we had like even fifth and sixth as well. And even just to make things, just to make it more clear, we roughly speaking had a table of 10 million rows. In each rows, we have all the data of one person, everything. I mean, it's not exactly like that. Of course, it was no real table, but roughly speaking, we could have a table like that if we really wanted to. Okay, so now I'm going to the case study. And here is what happened. So in Israel, we have the first wave, the total lockdown, the second wave, a lockdown, the third wave, another lockdown, but not that strict. And the vaccinations arrived, and Israel got vaccinated very fast, which stopped the third wave. No infections at all during April and March, only people who April, yeah, March and April and May, I think even, and then it starts. People comes from abroad, bringing the Delta variant. This is a beginning, as you can see here. We see that it starts to go up, and we see that there is a rise in the severe cases in Israel. So I'm sure here everyone understands this graph. The reproducing number R is 1.4, 1.3. This is already, we see that during the end of June and beginning of July. It is clear that something is going on, but probably you know this cartoon. So public health going down, under control. Oh my God, exponential growth. It was clear already at that stage that we are going into a disaster. I mean, in Israel, it was clear. It took some time to convince people in public health, but as our modelists already understood that at the beginning of July. Here how it looks. So we see here a graph that was observed during the decisions, when the decisions were taken or were considered. The first, I think, SATAM, first advisory team meeting regarding what to do with the Delta. This is how it looked like. New daily confirmed cases per millions getting up, but not by much. Look at it when we see the same graph a month later. Okay, so it's really like that. The public, it's really difficult to understand that when it's still so small, it is going to be very large soon if you don't stop it by some means. To understand the dilemma, you have to understand that in Israel was a unique situation. So at March already, most of Israel was vaccinated, both the elderly and even the young people above age 16. Just to compare the next states that it was in a similar situation, a highly population level of immunization, was the US about 4 months later. And in this stage, everyone in the US, mostly the vaccination is still, let's say, new. In Israel, it started, it looks like it started to fade or to wane. Okay, so this is the situation, and here is the dilemma. Is COVID vaccine protection fading? Because we see we see people in hospitals. We see that the R is going up, and we are in a crisis. Or is the Delta variant evading immunity? Or is the Delta variant more infectious? So depending on this question, depending on the answer to this question, there is different in what you should do. Should you administer the booster vaccine, wait for a new vaccination, or expand vaccination coverage to do it also for children and people who didn't vaccinated? Although in Israel, I think back then we already had about 90% coverage of the elderly, which is really amazing. Okay, so why not give the booster? So first of all, no FDA approval. You have to be very brave to give a booster when it was not approved. Should Israel be the first? It's not adapted for Delta. Should we wait? What about safety concerns? Nobody knows if it really works or what are the safety for people. And should Israel risk another lockdown? So that was the dilemma. And I have to say that this slide that you see here, I took from Nachman Ash, the Director General of the Ministry of Health, and also the whole dilemma, also some of the other slides in this part I took from Nachman. And here is what, because we are scientists, it's more difficult for us to understand this graph because we are here. But I think for him, and he said, and I left it here as a policy maker and not makers like all the others, because he felt that all the responsibility was on him. And this is true. At the end of the day, he should understand. He had to give the decision whether to give the booster or not to give the booster. And he said a lot of pressure from politicians to open, to close, to do that and to do that. A lot of pressure from the media. And as you see, a more healthy, I would say, a relationship with the advisory committee, which really helped and was really positive in general to help and work together. I have to say, I've been to a few of the Tzatam, of the advisory committee meetings, and to see 60 people, all of them really high, very senior, and still succeed to work together in a Zoom meeting, this is very impressive. And us scientists also helping the advisory committee get questions from the advisory committee and prepare for the next meeting, and also talk directly to the policymakers. This was really part of how it worked. Okay, so I want to try to not talk too much. Okay, so let's understand, this is roughly what we presented, not this very nice graph. I think I have the original graph we presented, but this is roughly the graph that was presented to the Tzatam, to the advisory team. And what we see here is a little bit complicated slide. So we are talking about waning immunity. This is on data that was collected between July 11th and July 31st. We are looking at confirmed infection rate per 1,000 people. And let's look at the age 60 and above. This is what most interesting. And what we see is that people that were vaccinated in the first period, having about 4 infection per 1,000. And people who were vaccinated later, 2 weeks later, they already have only 3 infections per 1,000. And people who were vaccinated in the next group, the same, less and less and less. And we see this staircase graph style. And this was very convincing. We see here the same graph for other ages, roughly the same. However, people who were vaccinated at the beginning can be healthcare workers or people at risk, which can change a little bit the dynamic. But I have to say, in Israel, most of those who vaccinated here were not healthcare workers, because there were enough vaccinations and people just got vaccinated early, and that's what we saw. So we presented this graph, not as nice as this look like, and this graph as well, which is a graph for severe cases. The previous one was for infections, and this is for severe cases. This, because there are not enough, the numbers were much smaller, so we see here in a period of months. So those who vaccinated in January has 1.3 cases per 1,000, and those in February less, and those in March less, and April and May less. And we presented one version like that at about mid-July, and later on we presented with much more information. Again, this is the rising of the pandemic. So in the beginning of July, there were almost no cases, and 2 weeks later, we have 10 times more cases. So it's really changed rapidly. So we had much more information in a week or two. So the second time we presented it, people were much more convinced. Of course, this was not the only things that were presented. People presented regarding safety, for example, because there were people who got the third vaccination, the booster dose, because of vaccine immunity problems or stuff like that. But this was convincing to understand that what we observed here is waning of the vaccination, and that's why, based on the evidence of waning immunity in Israel and given the rapid rise in severe cases, Israel decided to begin a third vaccination campaign on July 30th, starting with the elderly, 60 plus. And this is really a brave, I would say, brave decision by the Director General of the Ministry of Health, because, all the responsibility was on him. And I think it was really an evidence-based. That's what he looked for, and that's what he did. Okay, so after the booster was given for the elderly, it was very important to understand if it works, because the decision if to continue this vaccination campaign to other ages, other age groups, depend on whether it helps and whether we see a lot of side effects or stuff like that from the third dose. So this is a real, this is really like, we did it and send it, to the SATAM, to the advisory team, very fast. So this, you can see here, this all the intervals are censored or whatever. This is just because it was done so fast. We see here results based on Poisson regression per day, how much the vaccination, the third vaccination protects compared to people who got only 2 vaccinations. What we see here is that on the first day after vaccination, people are very protected. This goes down to a little bit protected and then goes up again. And why we see this I would say, U pattern. So people who get the vaccination in the beginning, they're usually healthy. If they think that they are not healthy, they won't get the vaccination. So to get vaccinated. So if they are vaccinated, they are usually healthy. After that, we may see that vaccination is still not protecting, and then it goes up because of the protection. And this was enough. This graph was enough to convince the Ministry of Health to decide and give the vaccination to the 50 years old, and later on, a week later, also to other age groups. So this, you can see it here. So this is the third dose. You can see here, it started on July 30th. And in, I would say, I don't know, 2 weeks, 80% of the Israeli population above age 60 was vaccinated. This is really amazing. And you can see here, the 50 plus started a little bit later, also very fast, the same for all age groups. So in 1 month, Israel got the third vaccine, and it stopped the Delta variant. There are really amazing analysis of what would happen without the booster in Israel and other stuff, mostly by our parallel team, the modelists, which probably more interesting for you guys. But this is the what we showed. Okay, one last lesson I want to show, and then I'll go into summarize my stuff. So same analysis. This is the same analysis, but with a nice graph we did later on. But we did the analysis. This is the same analysis, Poisson regression analysis, based on how much people in the beginning. There is some protection because of healthy vaccinee. Go down in the beginning because the vaccine does not has no effect in the beginning, and then it goes up, as you can see, to about 10 times protection compared to those who already have two doses of vaccination. So this is the same analysis as I showed before, but we try to do the analysis in more than one way. So we did it again using matching, using the techniques of Dagan et al. And what's the name of that guy from Harvard? Causal inference. So this was done similar to what they did. We also used that fact that 3 days after vaccination to 7 days after vaccination, people are not really protected by the vaccination, and we use it as an internal control. So here we control people who were here and moved here. So these are not different people who did not get the booster. Those all got the booster, but here's are in the beginning and here's are later on. And we see here the same, that the protection is very good. So we did the analysis in 3 different ways. We actually did a 4th way, which didn't work very well. We tried it on people who came from abroad because they were tested before going up, before arriving to the airport or at the airport, and we had that data as well, and we tried to see what happens to them, but this data was not rich enough, and we couldn't get to any conclusions. Okay, so now I'll just summarize and what are the lessons learned in my opinion. Of course, Jacob showed a lot of lessons that were learned. Most of them, I mean, there were more than one team. All of the teams wrote their parts, and it's not only from Israel. But I think the main lessons are those. First of all, people. It's very important to build trusted academic government teams before the crisis. You need to fund them. You need to recognize the contribution. I mean, as I said before, if you talk to a researcher and say, please help the Ministry of Health, it won't give him tenure. And this is very important, to find a way to help academic researcher to work with the government without that harming their career. So this is, I think, the most important part. The second is data. the national data infrastructure, linkage, quality control, analytic pipeline must be ready before they are urgently needed. So, as I said, we had amazing data working with the Ministry of Health, but the beginning months we didn't have. It took us months to build that structure. I mean, not me, but it took the Ministry of Health months to build that data and the way to work with the data and the servers and everything. And in the beginning, we didn't have such great data. So it took almost a year, I think, to get to the levels that you have, roughly speaking, everything you want to. We didn't get everything. We asked the director general to give us permission to see all the registries of diabetes and cancer and everything, and to merge that as well. Because of privacy issues, it was not done. Although he allowed us to do that, at the end of the day, the BI didn't do it for us. So we didn't have all the data we wanted, but we had a lot of data. But I have to say that this is unique. I mean, this is a unique time, because now when I try to work with the Ministry of Health and get data from different sources, this is a headache. I get it but it's a lot of work. Decision support. So it has to work together. I mean, there are teams in the Ministry of Health and other agencies but the teams that work with them should work on a regular basis. Otherwise, it won't work. So it should be even in times of routine times, people still need to work together, because it's very difficult to build it fast. It takes time. So, well, that's the last lesson, and this is what I wanted to say. So thank you very much for listening, and I'll be glad to get questions.
Thank you very much. Jacob, do you want to take over?
Yeah, I'm start the discussion. I'm gonna share my slides again for a second, just to show the questions. And yeah, those are standardized questions to all the people that we have in this series, more or less. So the first question is, assuming, and it has two parts, so let's go one by one. Assuming you have all the data you want available, like in Israel, it's pretty much the situation. But can we truly focus the pandemic through modeling?
Okay, so one reason I really wanted Amit with me is that he is the modeling guy. I'm just a statistician, but I'll just say that I think that first order approximation was good enough. That's what we learned. So it's not probably, everything that exponential is very difficult to predict, because a small deviation in the beginning will take you a very big difference in a few weeks. But for first approximation, I think it worked well for us, and I think I showed that before, that we understood very fast that Israel is going to a crisis because of the Delta variant, way before we saw a real rise in the cases. We understood already, because we saw that R was way above 1. So I think, yes, we can do some of it. Maybe not what will happen in the year to come, but definitely for the few weeks ahead of us to get ready, I think that first approximation can be good enough, especially because decision has to be made fast, and this has to be made on not too much data. I mean, so yes, I think we can, but again, not very well, but good enough.
Okay, let's follow the second part of the question. So you assume that we can forecast. Can we explain the pandemic?
So again, what I'm talking about, and again, I'm not a modelist, but I worked 2 years with modelists, so learned some lessons. So I think, again, that the beginning of the pandemic can be, when you are in the beginning of the pandemic, you can understand something. You can do a first approximation and explain it. How well it will continue the forecast for later, I think that's a more difficult question. I think that with trust, people will understand what you are saying. And this is what I said before. So if you remember the cartoon I put, the one with the going, going down, okay, it's a stable and at the end, exponential growth. So I think that when there is trust between scientists and decision makers, they will believe you. Otherwise, they'll prefer not to believe because it's easier to think that nothing happens.
Okay. So you're positive about the ability to explain the data and be able to extract information from both for forecast and explanation. This is a good answer. Thank you. You're optimistic. The question is whether it's right.
I am optimistic. That's true
Yeah,
in general.
okay. The second question: if a pandemic happened today, are we ready as modelers?
Okay, so I think that a lot was learned in many places about pandemic. I mean, of course, I knew nothing about pandemia before I started to work, and many people didn't know anything. But 2 years into the pandemia, we learned a lot. So now, if we'll have it now, we are ready. 10 years from now, we probably won't be ready if we won't work on that. And this is the lesson I try to convey. It's not enough. I mean, especially for small country like Israel, we have 2 modelists, 3 modelists in Israel. That's it. We don't have many people here that can do the modeling. It's not like the US that you have many researchers that can do it. In Israel, it's really small, and we should, and we started with that, do work on that. So we gave one course about pandemic modeling in jointly to all Israel universities online. We did a workshop on that about a year ago, and we should continue with that because this is very important to keep our abilities and not let them get lost.
I think you just answered my continuation question. What do we need to do to be ready? So you just answered it, unless you
Yeah.
want to add more.
Yeah, no, that's what I wanted to say. So yeah, I didn't see the question, but I think so. We should continue doing that. We should continue keep the abilities that we already had. I'm very sorry and very disappointed, I would say, that the Ministry of Health succeeded to do in 2 years something that is unbelievable in getting so much data harmonized to the same system and stopped with that. And it's very, for me as a researcher, I work on cancer research and autoimmune systems, not related usually to vaccination. Now a little bit with the Ministry of Health, we continue to do stuff regarding influenza and RSV, but this is really not my main research. But combining data from the different HMOs on cancer, breast cancer, that's what I do now. It's very difficult, and I mean, it's there, but we cannot harmonize it easily. We can, but it's very difficult. So this is something that we have to get better in Israel.
While people become less shy, I have another question. The first
Sure.
thing you said in your slide is people. People, which makes sense a lot if you want to do this. But now you have AI on the horizon. So how do you think things will look in the future? This is like an open question.
I mean, this is open question to all of us, I think, here in this forum. I have to say that AI changes so much, and as a teacher in my institute, I find that I still don't know what to do with it. I mean, it difference how we teach people, it difference how people work on questions because you can learn much faster than it used to be on one hand. On the other hand, at the end of the day, I still think that people is the most important part because it's the only way to convince policymakers to decide to do evidence-based decisions. It's really difficult to just, put your faith in AI. So I think it's still there. People both understanding, learning, getting ready for the next pandemic, and also, getting connected with the policymakers. And I mean, there are a lot of work to do that is routinely related, for example, for vaccine effectiveness in RSV and influenza, but in other, I mean, getting ready to earthquakes, getting ready to other disasters. So all of that still should continue, and I think still people are the main factors that can do that.
I would like to ask where, I mean, this group was set up because there were lots of people doing epidemiological modeling, but not so many people doing in-host modeling of actual immune response to infection and to vaccination or therapy. What, if anywhere, do you see opportunities to connect in-host scale forecasting with population level forecasting?
These really questions that are above my level. I should have Amit here. I really don't know enough about modeling to answer such question. I'm sorry. I know this is a modeling group, and I'm not a modelist, so I don't know. It's
Well,
really,
so maybe a different way to ask the question would be, what if we could make some predictions about particular aspects of individual response, for example, predict infectivity profiles after infection for a variety of different situations, or predict which people are most likely to become seriously ill and die. Some of that, of course, you could do by classic stratification. Maybe we could try to focus on actually understanding where the decrease in vaccine efficacy comes from. What are the kinds of questions that you think might be most useful for people who are focusing on what's going on inside of an individual, be in the context that you've been describing? As an example, we had Chantal, who was a member of this group, hasn't participated for a while now, but she focused on aerosols. So both on the number of viral particles expelled when somebody coughs, and also when people inhale in an environment that has some amount of virus in it, what the probability of infection was, and also questions about viral viability and particulate suspension. So that would be an example where you could perhaps calculate more accurately the probability of person X infecting person Y in a certain encounter. So those are potentially all kinds of questions that people in this community might be interested in trying to solve. And so coming from the public health point of view, are there any places where you say, well, that might be of interest? And if the answer is no, that's just fine. But I was trying to give you a little bit more guidance about the kinds of questions right around.
Thank you. Yeah, now I understand the question. So actually, we did in the beginning a lot of simulations to understand how to predict what is going to happen using modeling that models the population in the cities according to how much they are going to get infected. Roughly speaking, using a matrix that discusses the ages and how different ages interact with different other ages, and parents with kids and teachers and all of that. So definitely there are a lot that can be get into these models, and I think this can be helpful. And I had a lot of interaction with the modeling team that did such stuff and worked parallel to us, because they always had to look for parameters for their analysis. So I used to work with them closely to help them calculate such parameters. So yes, I think the more we know, the better our models can be. And I think we can, especially, I mean, in Israel, at least we had the high level data. I mean, for some person, we could get high level data, especially the HMOs themselves, less the Ministry of Health, and they could do really testing to see who are more infectious, who is less infectious. We did it a little bit using modeling like house modeling to see what happened with children, but not more than that. But there were teams that worked parallel to us. In the beginning, there was so many teams, so one team really did exactly such a model.
Well, I remember we had some speakers from Israel during the epidemic, and there were very impressive models available because of the quality of the Israeli data. They were really, you had much more information, detailed information than you did almost anywhere else early on.
Yeah.
And that was, maybe it's worth coming back to some of the speakers that we had from 2020, 2021 from Israel and revisit some of the conclusions that they might have made. Are there any other questions from our audience today? Well, I thank you very much for talking about the social and political context here. That's something that we often, we tend to be a very technical group, and we forget that the modeling and the techniques don't do any good if they're not rolled out in an effective political and social context. So I really appreciated that perspective.
I
Jacob,
think
go ahead.
I think Lorenzo has a question, but he has privileges, I believe, to speak, correct?
Yeah, a wrap-up question, really. I wrote it in chat instead of saying is, policies has changed. During COVID, we were all excited. We have to work together. We have to be prepared and address the problem. Then it's resolved somewhat, the pandemic, and we are all back to business as usual. How do we prevent that? How we go back to collaboration in all domain of medicine, not only viral disease? There is plenty of stuff that we cannot only work when there is a pandemic, can't we?
I couldn't agree more. I couldn't agree more, and I think this is the most important lesson, in my opinion. We really have to continue the collaboration of academia and the Ministry of Health in my case, but in general in policy making agencies. All the time, we should fund that. We should encourage people in academia to do that, because usually people don't get anything from that, and they don't get tenure, and they are not appreciated on working with I would say political agencies or decision-making agencies, and this is should be changed. Should be a way to do it. I would say like a reserve, that people go to do their second job working with, say, Ministry of Health for a month, a year, or something like that, to keep contact with the people who work there, keep their abilities, keep the collaboration, do some workshops, do stuff like that. I think this is the most important lesson.
Thank you.
Okay, that's a great place to end for today. Thank you so much for speaking
Thank
to
you
us.
very much.